So thank you, Amit, for giving this opportunity to share these thoughts. The reason to select this topic is basically, I think IBS is anybody's diagnosis. It's not uncommon to see majority of us are patients. Really not uncommon to just see the patients who just come and tell us that, doctor, I think I have IBS and it is diarrhea predominant IBS. So we are most tempted to tell them, kindly treat yourself, so if you know so much about it. So it's a long-standing chronic disease. Majority of the time self-made diagnosis, because nobody likes to learn the criteria, as Adi mentioned about Rome criteria. Most important thing is that we need to understand the myths and realities of GI disorders, and it's a huge psychological burden actually for the patient also, because they keep visiting doctors from one specialty across other specialty, and it's a burden to the patient as well as the family, financial as well as psychological. Nobody really likes to know the criteria. I myself don't like the criteria to be by heart, so because they are readily available nowadays. But this is the only slide concerning criteria in my entire lecture, so don't worry about that. So the quickest way to know is IBS means, if you have an abdominal pain which is recurrent for at least 3 months, onset before 6 months, and it should be associated with one of the following, like pain should be associated with defecation or change in the frequency of stools or change in the consistency of stools. The later part we will see later. So what things would favor? Basically the talk is about not knowing treatment of IBS. It is to see how you can differentiate functional bowel diseases versus IBS. Functional bowel diseases versus organic GI diseases. So which things would favor a diagnosis of an irritable bowel syndrome, which is a functional bowel disorder. So many times you would see people would also have these symptoms. Like symptoms would be from other organs, like from esophagus or gastroduodenum. Like there would be belching, reflux, heartburn, bloating, flatulence, functional constipation. So people with IBS are known to have these symptoms more commonly as compared to general population, which we tend to term as dyspepsia. These are other somatic symptoms. So these are somatic overlaps. So these would be people who will be having backache, limb ache, headaches, migraine overlaps, not very uncommon. Menstrual disturbances, dyspareunia, insomnia and lethargy. This is really common if you really go down to see. We tend to label these people as having psychological illnesses, or she is really functional. That's how it comes. There are defined somatic syndromes which do overlap with IBS patients with IBS, which are fibromyalgia. I think common diagnosis with rheumatology consultants would like to consider. Interstitial cystitis, chronic fatigue syndrome, and certain psychological disorders. So these are very defined somatic syndromes which do have a definition. So we need to look at that. If your patient has one of them, you can make a diagnosis of IBS with little more certainty. So why am I discussing this? Are there any IBS mimics, or is there a grey line between functional and organic disease? Now this was essentially, the line was in one of the articles by in European journals about IBS and its overlaps. So they wanted to change the criteria to evaluate patients with constipation and diarrhea. So they wanted to include certain investigations or certain serology while investigating them. So these are real overlaps of irritable bowel syndrome. Now IBS has got 4 varieties. We have IBS-C, that is IBS constipation, IBS-D, that is diarrhea, IBS-M, that is mixed, and IBS-U, that is undifferentiated. So these are all the overlaps. So celiac disease, inflammatory bowel disease, SIBO is small intestinal bacterial overgrowth. These are common. Chronic GI infection, it's all over India. Pancreatic exocrine deficiency and bile acid diarrhea, they are not really very common in a clinical practice. Pancreatic exocrine deficiency not common because our fat intake is not as much as you would have in Western population. As far as IBS constipation is concerned, the 2 most important differentials you would like to consider will be colorectal cancers and uncomplicated diverticular disease of colon. I have included one more thing, such as subaqueous intestinal obstruction or adhesions. This is little clinically difficult to evaluate, especially in women who have got previous surgeries. So this is how either a patient would look, or a gastroenterologist would look, or any clinician would look to how to make a diagnosis. Why there is confusion? Because how much ever said, how many criteria are there? See, there will be Manning criteria, Cruz criteria, Rome 1, 2, 3, 4. So many criteria have come and gone, more will come. So many times symptoms are not very useful in making a very certain clinical diagnosis. The performance is not very accurate. You have to be at best of your clinical efficiency when you are evaluating a patient, examining and asking history. You may still be at a benefit because you are seeing the patient for the third time or fourth time. And impact of invasive tests, like patient would be concerned about the money that they are spending while making the diagnosis, and availabilities of health facilities as it is always there. So history would be very important, maybe for junior or resident physicians. Extremes of age, onset. I would like to quote one example here. Maybe 3 to 4 weeks back, one of my surgical colleagues operated on a patient for diverticulitis. This patient was seen by me probably 4 months back. The patient actually complained that Dr. Bapat did not ask us to do a CT scan. This gentleman, if I remember correctly, had symptoms for several years with only mild pain and intermittent constipation. So they were not good enough to ask for a CT, but probably that taught me a lesson. So had it been diagnosed before, would he have been able to prevent an attack of diverticulitis? So that is something we need to know. So sudden onset of symptom, extremes of age. Obvious food intolerance. Indian cuisine is extremely rich, and I keep telling my patients that we would not know, there is no point in doing these food allergies unless you have allergy symptoms like rash or breathlessness, because every individual may have different allergies. The GI bleed may be intermittent, it could be occult. Weight loss could be intentional. COVID has really taught us many lessons that any existing disease can be sudden, maybe unmasked after getting a COVID attack. Anorexia, fever, low-grade fever, family history of cancer, family history of IBD, lumps and masses, and manifestations like paraneoplastic syndromes. Examination has to be complete to look for detailed evaluation of pallor and lymph nodes, edema feet, which just could be cardiac in origin, pigmentations in the throat, tongue, buccal mucosa, joint, skin, eyes. Ask for these symptoms, they are not very uncommon, to be honest. Scars of prior surgery and syndromic manifestations. Like carcinoid, you may see a lot of asymptomatic carcinoid. The actual carcinoid syndrome may be really very rare to see attacks of breathlessness and rash all over the body. So the problems are, you have, this is my most favorite slide. Now, if you see, we are in an era where we practice polypharmacy and multiple diseases. It's not unusual to see even a 40-year-old gentleman with diabetes and history of PTCA done, or a younger patient with who's done a solid organ transplant. So we are in a different era. We need to know a lot of diseases, a lot of conditions, a lot of drugs and their interactions. So diabetes, thyroid, HIV, they each will have impact on your GI behavior, constipation, diarrhea, pain, opportunistic infections, especially in solid organ transplant. Like you may have, it's not unusual to see patients after kidney transplant for diarrhea, and you do a biofile, you do a stool biofile, you just find norovirus. The only treatment for that would be just to decrease your transplant treatment, the immunosuppression. Cardiovascular diseases, GI ischemias in the form of vasculitis, drugs, very common antiplatelets, clopidogrel, every alternate patient would be on that. Neurological disease, Parkinson's can cause constipation, the medicines can cause constipation, obesity and common food intolerance. FODMAP is the recent new, if I can say. So how do you solve this problem? So constipation, we saw 3 differentials. One was a colorectal malignancy. Anybody can miss this, but generally adult patients, very short and sudden onset. Another example I would like to quote, a 54-year-old gentleman just walked into the OPD last week, and he said, I just have what is called a slow transit constipation. Initial stool frequency was 2 per day, solid, well formed. Now I am passing once in 2 days. No weight loss, no bleeding, no anorexia, non-smoker, diabetic, well controlled, PTCA on antiplatelets. Enough for me to think this is just a change in his pattern. Somehow I thought because he's 50 plus I should do a colonoscopy. We found a rectal growth. So this is not uncommon. So endoscopy and biopsy, whenever there is any concern, I sometimes fear that we are in a world of defensive medicine. So if you have a suspicion, do a cross-sectional imaging after speaking to the patient. Uncomplicated chronic diverticulitis, I just gave you an example. Now generally these are longer durations. Patients may recall the episodes of constipation and pain before as well. Frequent attacks of these staggering attacks, and again even plain imaging would do. Maybe you are seeing a patient who's old, who has diabetes, who has hypertension, they have nephropathy, they don't want to take contrast. there are lots of things you have to think about when you're asking for a contrast cross-sectional imaging. But you could do a plain CT. Ultrasound, you can speak to the sonologist and ask them, please look for these things. Sonography is not a routine investigation for intestine because it really doesn't pick it well unless it's something big. Omental pathologies can be really missed, especially in young women who are suffering from infertility. So they may have bloats and irregular bowels, and suddenly you may just find omental adhesions or omental nodules. So cross-sectional imaging or transvaginal ultrasounds can help you, and often the answer will be in histopathology. Diarrhea. First important thing to know is that you should know what is diarrhea. It's increased frequency as well as the consistency. It's not the solid stools that patient is passing 3-4 times. That's actually a hyperidification. It's really beyond this scope of this lecture, but if you all see GI patients commonly in your clinic, once at least you should see what is called as a Bristol stool chart. It tells you everything in detail so that your concepts of learning how to interpret constipation and diarrhea would be made ascertained. So celiac disease, it's not very difficult diagnosis actually, because majority would get investigated in their first decade of life, but however if it's up to second decade, they would have bloats and belches. So TTG IgA has been made as a investigation that you would include whenever you see a patient who's suffering from diarrhea. So it's quite okay to ask for that. Indeterminate IBD means you are not able to decide whether it is ulcerative colitis or Crohn's. No. It's a lot of people who have connective tissue disorders who are indeterminate. It is something like that. So you have oral ulcers, aphthous ulcers, psoriasis. You have some other skin diseases. You could have bowel inflammation. You can have a small and large bowel inflammation that can cause something like an inflammatory bowel disease. To be honest, microscopic colitis, collagenous colitis is not very common. Even macroscopic colitis is not really that common. They will have multiple stools, small quantity or moderate quantity, no bloat symptoms. Bloat symptoms are essentially small intestine. Whenever patient complains of bloating, belching, they really abdomen, they may tell you that our tummy has gone up now, they are suddenly put on weight. So they are small bowel diet related issues. Again, endoscopy and calprotectin, I'm not so sure whether it can give you a diagnosis. You can do a stool calprotectin. It may cost your patient around 2,000 to 3,000. The problem with this is it's a protein which is secreted by neutrophils, but labs can have variation, and every center may have their own cutoffs. So unless it is very high or unless it is very low, it may not be very supportive. But it's a standard investigation which is guideline recommended. Chronic GI infection, very easy for patients also already go to, or just take gentle. It's not very uncommon. So generally you have central discomforts, watery stools. You may have raised eosinophil unless they have associated allergies, exposure to unhygienic food and travel history. You can do a drug trial rather than going through investigations. SIBO, not very uncommon, small intestinal bacterial overgrowth. Not necessarily everybody should have a history of surgery before, but generally these are people who have low transit intestines. So if you have a suspicion, look for alarm features, investigate, and then make a diagnosis of IBS. If there are no alarm features, you are pretty justified in considering that your patient has an irritable bowel syndrome. So these are in short mentioned in the Rome criteria as well as some additions. This will prompt investigation. Age of symptoms more than 50. Again, for every line there would be an exception which you all must have experienced. Recent change in the bowel habit, rectal bleed, how much ever you think it is hemorrhoid, you should suggest the patient that please undergo sigmoidoscopy. If not, at least evaluate further. Bleeding is a very important alarm sign. Unintentional weight loss, worsening of symptoms, prior histories, radiation, colorectal cancers in the family, IBD in the family, and any palpable mass, or any imaging or any investigational evidence that there has been bleeding or anemia or evidence of inflammation, like you have pus cells in the stool or RBCs in the stool or ova in the stool, not ova. Investigations which matter would be low hemoglobin, iron deficiency, raised hemoglobin, high eosinophils, low vitamin B12, TTG, thyroid profile, glycosylated hemoglobin, stool. Please do stool routine also whenever you are doing, rather than sitting only for stool culture and doing stool open blood. High stool calprotectin. ESR and CRP may not be very helpful always. So we generally don't ask for that. So when your eyes cannot see, take help of imaging. These are things which could be missed on your clinical evaluation on ultrasounds and X-rays. So diverticular diseases, like you see, the left upper panel is for omental disease. She's a young girl referred from infertility. Chronic diverticulae, paraduodenal or internal hernias, which may not be appreciated well, and abdominal lymphadenopathy. So seeing is believing as an endoscopist. It's not because I'm an endoscopist I put this slide. But these are all patients who have just come with very minimal symptoms. The second slide is which I told you about, the man who came with constipation of recent onset. The first slide is of a lady who had diarrhea for almost 1.5 years, and only one stool had shown RBCs and pus cells, and there was no calprotectin. So considering her entire profile, we had asked her to undergo. These are cecal and ileocecal ulcerations. The third figure is of a distant cousin of a child who was suffering from celiac disease. And last is diarrhea, which none of us had expected. This gentleman had low-grade lymphoma. So eosinophilic injuries, vasculitis, villus atrophies would be diagnosed only when you do biopsies. I think this is second last slide. Okay, FODMAP. I don't know whether I should include this. FODMAPs are the new diets which are, if you all know, these are fermentable oligosaccharides or disaccharides and polyols, which are essentially something like gluten-containing carbohydrates which are fermentable, and then they get fermented in colon and give you a lot of bloats and aches. So low FODMAP is something new which has been prescribed for IBS patients. So take-home points would be, we should know that IBS and organic disease will have often overlaps of symptoms. They are not very uncommon. Some people who suffer from IBD or suffer from diverticular disease or suffer from any other organic disease can have functional symptoms. So we should know where to keep a balance rather than augmenting their treatment. So very careful approach and a proper history and modest use of investigation should be able to sort out all your issues. Thank you.